Director and Senior Scientist for the Institute for Community Research. She is an anthropologist and social and behavioral scientist. Dr. Weith conducts community-based applied research on prevention of HIV, AIDS, and other sexually transmitted infections among urban U.S. drug users, high-risk women in the U.S. and China, and other at-risk populations. Her research includes development and testing of HIV/STI prevention programs in collaboration with other community research and service organizations, and examination of systems factors that contribute to disparities in new infections and comorbid conditions that affect disadvantaged, hidden, and stigmatized groups. And for us, she's going to talk about the Risk Avoidance Partnership, the story of a peer harm reduction intervention for drug users. Yay. Good morning, everybody. Good morning. Thank you. Are you awake? We all are, I'm sure. So I'm going to talk about this project, but there are a variety of different nuances of issues that I'll bring up as I give the presentation. So I would like to suggest that if there's something that I'm saying that is not entirely clear, you can just ask your questions right away, but I want to be sure that we have some time at the end as well to have some discussion. So, but if you have a burning question, you didn't understand something, don't worry about interrupting with a question, so feel free to do that. So thank you. I'm really excited to be here, to be doing this, because I think that this is a really important program. It's very exciting. And so I'm also happy to be sharing this experience that reflects about 15 years of research that I've been part of over quite a long period of time, starting in the late 90s, before many of you were born, I'm pretty sure. And so this is the Risk Avoidance Partnership. The basic model of the Risk Avoidance Partnership project is to train active drug users to be peer health advocates, or PHAs. And they got used to being called PHAs, came to love the designation. And so it has three primary components. One is a training curriculum for the drug users who would become peer health advocates. And that was based on a combination of role modeling for them and also training them in persuasive communication, and in addition to basic understanding of health, HIV transmission, and so on. The second component is that the trained PHAs would provide a modular peer intervention to members of their networks and other drug users in the community. And that component of the program is based on a harm reduction philosophy and on the concept of health promotion. And then the third piece is the community advocacy group, which is just a fancy name for anyone who went through the PHA training program, meeting monthly to sort of stay connected and stay with the program. And I'll talk more about each of these as we go on. But I want to step back for a minute and talk about how we got to the point where we could develop a peer intervention program because of some basic questions that we had. And this also reflects kind of the state of the science in the mid to late 90s. Prior to that, there had been such a tremendous emphasis on individual level behavior change interventions, really individually focused. And a lot of the social scientists were beginning to say, you have to look at social context. You really can't take the person out of his or her actual context if you're talking about risk prevention and the epidemic in general. And so this was a period of time when people really started looking at social networks in earnest. And we felt that that was an important piece to study as well if we wanted to think about a peer intervention, because a peer intervention is a diffusion intervention. And that means you really have to understand the places where people get together, which we lovingly called the high-risk sites, and the networks and interactions of the people in those locations. So we conducted, it has a much longer name, the study of high-risk drug settings for HIV prevention, blah, 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 something like that. But we just call it the high-risk site study. And it had the aims, first of all, to document the settings themselves where people were gathering to use drugs, the networks of drug users in those settings. And we were also interested in these two questions, the receptivity of people in those settings to a peer-delivered intervention, and the potential for diffusion of that intervention through drug-using networks around the city. And we were based in Hartford, Connecticut, which is, you know, in many ways it's a typical small to mid-sized city of which there are numerous examples in New England, around the country, and elsewhere. And it's a little bit different from the big cities, the big city dynamic, although one probably could argue that when you get drilled down to the neighborhoods, which is really where people interact, it could be very similar. So the methods, we use mixed methods, as we do in virtually every single one of the studies I've been involved in for the past 30 or so years. We used street outreach and intensive ethnographic observation of the drug use settings. We used exploratory in-depth interviews. We used site survey checklists. So we had our outreach workers and ethnographers going to all of the different sites that we could find out about through ethnography, and they checked off a few things like how many people tended to be there, were there needles on the ground, was there clean water available, a variety of different things. And we're talking about not just abandoned buildings, of which there were at that time something like 600 in the city of Hartford, but also people's apartments, you know, alleyways, a variety of different places that people go. And also then we did a cohort survey of about 300 people who we interviewed at baseline and 6 months with an epidemiological risk assessment survey plus a social network survey. And I'll talk about that a little bit more in a minute. At the time that this was happening, and even now, I mean, social network research is not new, but it was kind of new to HIV prevention research at that time, and people were looking at it for a variety of different reasons. First of all, as I mentioned, social context of people's risk behavior. It was also being looked at in terms of HIV prevalence in different subpopulations at risk. And, you know, of course, an interesting factor was, you know, people are connected in many, many ways, but if you're connected through, for example, needle sharing behavior, but there's no HIV in your network, you can do that forever. But if there's any HIV in the network, it can be a pretty rapid process by which everyone in your close network is soon infected. So people were looking at that. They were looking at how you might be able to track where the epidemic has been and where it might be going, and to look at social level intervention options, and particularly peer-focused interventions. So that's what people were interested in looking at through social networks, and I'd say people are still very interested in looking at that even now, because the epidemic still continues to evolve, and there is still a need for understanding social context as it does evolve. So this is an image that was drawn from the data from that study of the actual drug user network in Hartford at the time. And the way we measured it was we did a fairly typical procedure in which we asked people to name, we had a series of name-generating questions like, who do you do drugs, or who do you do drugs with? And who do you inject with, because you don't always inject with everyone? Who do you have sex with? And then we added questions like, who do you go to for support? And I think those were the primary things. We wanted to get we also asked if there were people in their network who they had particular conflicts with, because sometimes the conflict members of the network are also critical when it comes to risk and prevention. So this is who these drug users know in their network, you know, who's in their known network of using drugs. Who do you know who uses drugs? And you'll notice a couple of things in Hartford, especially at that time. It's a almost segregated city, so you've got no pointer working here. You've got the African American cluster, that's our north end of Hartford, and there's a few bridges, and then you've got the south end of Hartford, which was predominantly Puerto Rican, and that's the hanging off the tail end there, the white cluster. Networks like the city were very segregated, and in fact, drugs of choice differed in these different clusters. HIV prevalence differed in these different clusters, and so what you're looking at in terms of the structure is really just how people were connected. Then we did a technical network. We asked the question like this. If we were to find central network members who were non-overlapping, that is to say, we didn't want to duplicate our efforts, but we found the most central network members who were non-overlapping, and if we trained them as peer health advocates, could they, if they just talk to the people they know, cover this network? And the answer was, so those are the red dots. And the answer was a definitive yes, because the yellow dots are who they could cover if we just trained that 14 people out of, I think this is the main cluster. There are something like 169 nodes, which is individuals here, connected to each other in one or multiple ways. And basically, we were able, through training, if we were to train those 14 individuals, we would cover 66% of that main network cluster. But if you look at it, given the fact that there are not a lot of bridges between these two clusters, you couldn't train out all your people down here, or you would really probably miss people in one of the other main clusters. So we realized we had to recruit our peer health advocates from different sectors of the network if we wanted to be most efficient at reaching people. The very last part of the high-risk site study we actually got a supplement to do a pilot to develop the curriculum for our PHA training and to test it out with 10 individuals who were in the high-risk sites project. So we used that opportunity to develop the foundation for the RAP intervention. So now I'm going to shift back to RAP, Risk Avoidance Partnership, and our training program for the PHA. So we had 3 primary goals. First of all, we wanted to give them basic information in a way that they could understand, in a way that they could pass on HIV transmission. And a lot of them had, already some basic information. How is it? How can you get it? How do you pass it on? But there are a lot of nuanced misconceptions that we had to drill down into. We wanted to expand it to talk about other health issues as well, sexually transmitted diseases and hepatitis being big ones among particularly injection drug users and crack cocaine users, which were the 2 main drugs of choice in our city. And it's been expanded further as the time goes on to focus on other things like overdose and a variety of other health-related issues. We wanted also to focus on this concept of advocacy. What does it mean when you're an advocate? And that notion of you being a role model, but an active role model. We use the PHA to not just mean peer health advocate, but also public health advocate. And people really liked these ideas when they grabbed onto the concept. And then we wanted to give them very practical tools for how to get out there and deliver their messages in effective ways. So the curriculum was 10 sessions officially. The first 5 sessions got you the designation peer health advocate. So 4 of them were basically in office, and they came to our institute, which is, centrally located in the midst of, it's kind of in between the North End African American neighborhoods and the South End Puerto Rican neighborhoods, so pretty accessible to anybody. And each of the first 4 sessions were a combination of, didactic information delivery and lots of role modeling, starting with easy scenarios to, progressing towards much more difficult, what do you do with people who are resisting? What do you do with people who turn on you and say, who are you to talk? And so on. And so we role played a lot of those, and the people who were facilitating this intervention were themselves, a couple of them were past drug users themselves, clean for many years, and some involved in the project were not. So we didn't feel it was necessary for everybody to have had experiences with addiction themselves. But it's not a bad thing to involve people who have had direct experience, because they really do, understand in many ways. And I wouldn't say, that it gets complicated, because sometimes past drug users are less patient with current drug users than people who've never been there. So it's an interesting thing when you get people together working on a program like this. So the 5th session, which is, we did sessions 1 through 5 like this, Monday through Friday from 10 to 12, and it usually rolled into 12:30, 1 o'clock. They ended to, tended to go longer than expected. And by Friday, everybody paired up with a staff person. So we had 3 facilitators and 2 ethnographers, and usually around 5 trainees per cycle. And they'd go out and do outreach in the community, and the peer health advocate would do the interaction, and the staff person would just be there to, coach if need be, but mostly just stand back and then give them feedback after the fact. And then sessions 6 through 10 were just 5 more opportunities to do this, with the benefit of a staff person there as a coach, or just, to give them feedback afterwards. And then after they completed we had a certificate award on Friday, after they finished their 5 sessions. And they got little name tags. These, designations were all really important milestone markers, and also, just ceremonial things that were important to them. And then after that, they were eligible to come to the monthly community advocacy group, CAG meetings, which we had ongoing throughout the rest of the project. So we also had goals for the intervention they were to deliver to their peers. First of all, we really hoped that they would reach the high-risk individuals with these harm reduction and health promotion messages. That was, of course, the primary goal, that they would deliver the PHA intervention. We wanted them to be able to promote these messages. We, of course, wanted and hoped that they would be effective for reducing harm, increasing safety of drug users throughout the social network. And in particular, we were hoping that they would actually get into those high-risk sites where sometimes, many times, outreach workers are really not invited into, not allowed to go. But also, frankly, the average outreach worker works from 9 to 5 or 8 to 4. Or, sometimes the projects shift it up a bit and try to do late hours or what have you. But it's the 2 a.m. risk that is usually not met by an outreach worker, and we hoped that PHAs could sort of fill that void, particularly if they were present at those encounters. So we gave some structure to that peer intervention, because it needed some structure, and we wanted to make sure that certain things were covered. So we said, okay, so there are 3 general categories of this intervention. One is education, so you're giving them information about health, how to protect themselves, how to properly clean your syringes, and so on. And do it in a fun way, educational games or what have you, slogans. And a second component was to demonstrate, actually show people how, proper use of a condom, proper cleaning of syringes. And then the third component was to hand out prevention materials, which we provided to the peer health advocates, bleach kits and so on and so forth. And we said, for it to be a real PHA encounter, you have to do at least 2 of these. You can't just talk. You have to talk and demonstrate, or talk and hand out materials. You can't just demonstrate, you have to leave them with some. So we wanted it to be a deeper kind of encounter. So we gave them a tool. It's kind of hard to tell what this is. I should have brought my sample. We call this the Flipbook. It's basically a spiral-bound, fully laminated on all pages thing that you could flip up. And inside, so these were the different sections. And you could flip open to education, and it would show proper cleaning procedures. And it's a lot of pictures, easy to read. You could almost tell, even if you were illiterate, what was the message, how you were supposed to use it. And a lot of times the PHAs would pull these out and just flip through them page by page, or someone would take it and be looking through it. So that was how we structured the intervention that they were delivering. And then, of course, again, the monthly meetings, the CAG meetings, had several goals as well. First of all, bring people back together. And once you're trained with a group of, 3 to 7 people, you think of yourself as part of that group, but you don't necessarily see yourself as part of a much larger group of people who are being trained over time. And the CAG meetings allowed them to see themselves as part of this much larger movement of drug users being trained as peer health advocates. We sometimes organized speakers from the community to come in and talk about some other issues that were relevant and important to them, like housing, like insurance, health insurance, Social Security benefits for anybody with HIV, a variety of things that were really important to them. These were opportunities for them to sort of review again the intervention that they were delivering, and also it was an opportunity for them to restock with their prevention materials. So the ongoing monthly meetings were really critically important, because that's how we retained our relationship with them, and how they, had an anchor organization to come back to, and also had each other. So it became also just a social opportunity for them to hang out and chat with each other, and ultimately they saw that as truly beneficial in and of itself as well. All of this, this is the step back. Yes, there's theory. A lot of times people say, is there any theory behind that? And it's a multi-level intervention, so there are multi-level theories. Of course, the persuasive communication and the social learning theory are really behind the content and the model of the intervention, the one-on-one intervention that the peer health advocates were delivering to their peers, and also the one that we were delivering to the PHAs as we were training them. But really, the notion of close ties, appropriate messages that are often best delivered by peers, immediacy in the social and physical environment, geospatial environment of the person, and the repeated messages were part of dynamic social impact theory and social learning theory. Diffusion of innovations really talks about some of the same mechanisms of change, really trustworthy change agents, key opinion leaders, and this notion of diffusion and change in group diffusion context is happening progressively over time. And then health promotion theory, which really focuses on the notion of what is that? Give a man a fish he eats for a day, teach him to fish he eats for life, kind of a thing. For people to be empowered to engage in their own health promotion, their own health knowledge is really significantly more effective than just telling them what they ought to be doing. The evaluation, I mentioned a little bit what the structure, actually that was the higher sites I was talking about. So the evaluation of the RAP project was also mixed methods. We did a baseline assessment. This is a survey similar to the epidemiological risk and behavioral assessment that we used in the high-risk site study, plus the social network measures. of the people we were recruiting for peer health advocates. And we started out with this rigid notion of, okay, you have to get a central network member or somebody who is a gatekeeper into a high-risk site or something like that. We did that for a few cycles, and then the outreach workers started screaming, let us open this up. And we said, okay, yes. And turns out, didn't really matter. You could recruit anybody to be a peer health advocate. And we had all kinds of people who were effective in different ways. We didn't have to look for those central network members to be able to have an effective peer health advocate, which was a really good learning experience in that regard. But as part of our evaluation, before we started our peer health advocates training program, which, as I said, we did in clusters of 5 per training cycle, we required that they would bring in 2 members of their personal networks as what we called CRs, or contact referrals. And if someone came in as a CR for a PHA who was getting trained, we didn't allow them to come in as a PHA. They had to keep their designation because we needed to be able to compare the PHAs to the CRs at our follow-up assessment. And we wanted to know if the CRs would have been exposed to the intervention that the PHAs delivered. So we knew that we were intervening with the PHAs, but we did no intervention with the CRs whatsoever. So part of the 6-month assessment was to figure out if they had been exposed to any kind of peer intervention. We coupled this with ethnographic observations and interviews. We observed the training sessions, and we would do it sort of intermittently, so those who were facilitating didn't know when they were being observed, but it was kind of hard. The ethnographers were everybody was in the room at the same time, but like the official documentation was just sort of, structured in a way that, okay, they're always taking notes, but we know these are the official ones. And they also partnered sometimes to do observe the training sessions in the community to see how those went. And they still went on their own into the drug use settings, those ones that we could enter. And, over time, we just had access to a lot of the settings in the community, including often people's apartments. So they could just watch the daily goings on there and kind of see if there were any changes that they noticed. We did a post-training closing interview with peer health advocates about their experiences, and then we did a 6-month follow-up assessment of PHAs and CRs, regardless of anything. It was kind of like intent to treat. So if you came in as a PHA or a CR, we looked for you 6 months later, regardless of what happened in between. So we had a pretty good, we had an expected fallout between the baseline survey and Monday morning when the PHAs were supposed to start. So about 25% of the people we interviewed as PHAs didn't show up on Monday morning. And some of those were because they couldn't get their 2 CRs in before the Monday morning start date. And so if they did eventually manage to do that, they could come into a later cycle. But if they couldn't do it, we figured, if you can't get 2 people to do this, maybe you can't get, 2 people to clean their needles. So, but that, we thought was not bad. What amazed us, because we know a lot of times drug users are driven by incentives, and we gave, I think we were giving a $25 incentive for the survey, $20 incentive for each of the training sessions, which were 2 hours each. So it was about, $10 an hour. That's a pretty good take, especially if you're going to get $100 for the week. And so there was a monetary incentive, but we still thought, you're asking people with, chaotic lives to come Monday through Friday from 10 to 12:30. You couldn't really be late. We gave you one option for a makeup session. We were amazed that almost 90% of them stayed through the whole training program. So that's just like remarkable. And you'll hear why later. And then, of course, we asked them to come to those other follow-up additional outreach sessions in the community, and 80% did more than the Monday through Friday, came at another time, partnered session, and more than half completed 3 or more additional sessions. And then we also had a really good participation rate in the monthly CAG meetings. Over 70% came to at least one, and a lot of them came to many meetings. And just long story short, we got a 3-year extension for the RAP intervention to look for longitudinal effects of the intervention. So we had those CAG meetings going for 5 or 6 years. We had people who, from the beginning, stayed through that whole period and kept coming to those CAG meetings. So it must have been doing something right to keep them going. So here is now, it's kind of hard to see, so I'll explain this. You know, with the network software that we're using, which is UCI Net, you can plot out the network on a 2-dimensional map like this, usually by picking one question that you think is going to get as many people in the main component as possible. So in this case, it was like, who knew who in the intervention. You'll see a couple of things in, first of all, in RAP, and we had more people involved, but that whole division of North End, South End, and Hartford kind of has disappeared a little bit, and that reflects some changes in the city as well. The triangles are PHAs, the circles are CRs, the white circles are people who we didn't get a 6-month follow-up on. You can barely tell gray from black, but black means highly active, HAI, highly active interventionist. So this is the distribution of PHAs and CRs in the network. And the lines that you're seeing, the ties, are intervention ties. This is, have you given HIV prevention information, materials, or demonstration to, and in this case it was which of your network members. So in RAP, we added those 2 questions at baseline and follow-up. This was in the name generating. So I told you that we had mentioned who do you do drugs with, who do you have sex with, who do you trust, blah, blah, blah. But we added these, have you given any of these kinds of health intervention to, and who have you received it from? So you can see the little teeny tiny arrows on some of these. So there's some intrinsic peer intervention that goes on in drug user networks kind of all the time. I mean, it's something that people often do for each other. Help you out, you need a needle, I'll give you a clean one, or, you know, give you condoms. Hopefully they're not sharing. Anyway, so some of that was going on, but some of this is also reflecting the fact that we trained PHAs over about a 1.5 year period of time. So the earlier cycles may be reflected in the baselines of later groups of people who came into this study. So that's the baseline peer intervention ties. Here's the 6-month peer intervention ties. Let's see that again. Baseline, 6-month. So at the very least, if you want to know, was there more intervention going on at 6 months, the answer is clearly and obviously yes. But we started drilling down on a couple of dynamics that we expected, sort of diffusion of innovations type of dynamics. And we had these 2 hypotheses. One we called the additive effect, and the other we called the cluster effect. And the additive effect, we thought, well, if there, more is better. If there are more PHAs in your network, it's better. It's more likely that you'll be affected and that more people will be affected. But the cluster effect was this kind of tipping point notion where if you really get a lot of people closely connected doing it, that the dynamic will be more of an exponential change rather than an additive change. And so in looking at this, we actually found, and we found this also when we did those kinds of tests statistically using the UCI network. So here's an area of the network, and this is not mapped geographically. This is strictly the network analysis, where there are PHAs who are kind of isolated really from each other and from everybody else in the network, able to do intervention, but not a lot. And some of the, not particularly different from CRs who are, again, just the sort of natural intrinsic peer intervention that's going on possibly in the community. And that when you get more of them together, you get more and more peer health advocates who become highly active interventionists. But here in this area, where they're really densely connected, the amount of intervention that's going on is back and forth. By the way, peer health advocates gave intervention to each other, too. And to the point where even a CR who was never intervened with by us at all became a highly active peer interventionist just by learning from the PHAs around him or her. So it really had an increasingly effective impact on the social network, and particularly in those areas of the network where a lot of intervention was going on. So, and they got, through the CAG and just in general, through our ethnographic interviews, we learned that they got involved in a whole lot of other things in their communities as well. Of course, they came to the CAG meetings, but they also came to, we call them bleach parties, where we were filling the little kits that they handed out that had, bleach and, alcoholic swabs and filters for filtering the drug in the solution and so on. So they came and if they came and filled those, we would pay them by the hour. But, so they came and did that. They would talk about issues like housing. After we gave had someone come in and talk about housing, they were passing that information on. They went and demonstrated at the legislative office buildings. They volunteered in shelters and clinics. They worked with youth and pastors in their churches. And of course, prison being a revolving door, even while they were in prison, they were delivering their peer intervention messages. This is self-report, but they had no reason to tell us this. They felt really proud about it. Of course, there were also barriers to being able to complete the program and to carry it on, arrest being a big one. Homelessness, I can't tell you how many times someone, we would give them a backpack with the Flipbook and a bunch of prevention materials in it that they could use, because they have to be able to carry these materials around with them. Of course, if they're staying in a shelter, good chance that would be ripped off. So we had to replace a few of those. Addiction, the reason I said that, you can't always predict who's going to be a good peer health advocate. Some of the most central network members were central because they were dealing and being part of the dealing. Sometimes they start using, and when their use starts escalating like crazy, their ability to do something like peer health advocacy goes down. So there's this roller coaster kind of a thing. And people who were addicted but had more control, a little bit more control over their addiction, even if they weren't as well connected, could be very effective. So, and it was that and many, many other things that could change the ability of the person to carry on their intervention. And of course, who they were connected to and how they were connected to them as well. But there were lots of motivations that we discovered as we were exploring with them through in-depth interviews and observations. Why did they stick to the program? Why did they keep doing it? What was in it for them? And, we all know, working with drug addicts, they have exceedingly low self-esteem. Everybody thinks they are social pariahs and tells them that all the time. They have, terrible interactions with institutions of any kind and with family members very often because they've done a lot of things to burn their bridges. A lot of them really are looking for something positive that they can do. Really positive, that they feel like, I'm not all bad. And then people begin to say, oh, you're doing something for the community. So that public recognition and praise, that self-recognition for doing something positive, cutting down or abstaining from drug use, they talked about that happening a lot. A lot of times they said when they were at the CAG meetings, and we said, yeah, you're here. I said, yeah, when I'm in here, I'm not out there, hustling or doing something that I shouldn't be doing. A lot of them saw this as a stepping stone for future employment. They saw the facilitators of these interventions as kind of people like them, and well, if they can do this, maybe I can eventually get a job like this as well. Improving relations with family. A lot of times HIV was not the only thing that they were focused on. General health they had an interest in, and they saw this as really promoting general health. A lot of times they said, don't share that bottle, you're giving someone, the flu or something like that. It was like any kind of a thing. Again, I mentioned they saw staff as role models, that they thought, I would like to be doing this kind of thing, kind of in a more long-term way. Field observations showed us that they could do this intervention in any number of different kinds of sites, from open and public to closed and private. Wherever drug users gathered, a laundromat was, a famous gathering spot for reasons related to the exchange of drugs in that laundromat. But all over the place, soup kitchens, shelters, wherever, they were able to do the intervention. They had everybody established their own style. Shy people talked, one-on-one. Outgoing people talked, would gather a crowd. It didn't matter. They felt proud about what they were doing. They felt valuable. And staff identified this and really named this concept of role change for them. They really began to see themselves as taking on a different role in the community. Peer health advocate was a different role from the role that they had. And it was not only a role that they took on themselves, it was a role that their peers assigned to them as well. Here's an example of someone who was talking about how his peers recognized him. He said, I'm being called condom man and stuff like that. I have people in my building knocking on my door asking for condoms. So I have to tell them to knock at a reasonable time, because 12 o'clock, 1 o'clock at night, knocking on your door for condoms. During the summer, I'd go out on my own because I go to the park anyway, so I just bring my bag and just sit around playing cards. When they see me with my bag, automatically they know I got condoms in it. And he came, he did a lot of condom distribution for us. Basically, what we found from RAP was a couple of key things from the research. First of all, that peer interventions like RAP do expose more people to health information and health promotion than not having peer interventions in the community. They definitely go beyond what street outreach workers and health institutions are able to provide. That this kind of peer intervention was acceptable both to the peers who were trained to deliver it and to the recipients. And that is not to say that everybody was a happy recipient of the intervention. There were people who were, too wrapped up in what they were doing, didn't want to hear it. There were people who said, who are you to talk? There were all of those kinds of things that happened. But eventually people were able to sort of, brush that off and move on to someone else who was more ready to receive it, and maybe come back to that person at a later time. It significantly changed peer health advocates' self-perception, and it definitely reached people in places that were not open to outreach workers. So we decided, based on all those positive results, because once you have an intervention that you feel is really positive for the community, then the question comes, well, what do you do with it? Does it go on the shelf? Does it get, it gets, of course, written up in peer-reviewed journal articles, because, that's a responsibility that we have to disseminate it to the scientific community, but that doesn't necessarily move it forward in the broader community. And so we were looking for a way to turn RAP into a program that could be delivered in other settings, and had a long-standing partnership with one of the methadone treatment clinics in the Hartford area, the Hartford Dispensary. And so we started talking with them about the idea of, is this something that we could translate for a clinic setting, a drug treatment clinic setting? And so there were a couple of reasons we thought a drug treatment clinic setting would be a valuable place to do it. First of all, they talk to a lot of drug users. So they have a ready access to the drug-using population all the time. Many other institutions either don't or don't want to or don't acknowledge it. They often build trusting relationships with drug users. That's one of the ways they work with the population to help them with their treatment goals. A lot of drug treatment programs have other health-related training and intervention goals as well. They have HIV programs, they have hepatitis prevention and treatment in some cases, and so on. And when you really link and integrate HIV treatment with HIV prevention with drug treatment programs, it really enhances the benefit of both. So those were good reasons to think about drug treatment clinics. But what about RAP? I mean, do we really think RAP could work in a drug treatment clinic setting? So one of the first things we thought about was the fact that that whole thing about someone turning to you and saying, well, who are you to talk? You're still using. The PHAs were saying that to themselves. So who am I to talk? I'm still using. And we were amazed at how many started going into treatment. And everybody knows treatment is hard. Getting clean forever is really, really hard. So some of them didn't succeed, but a huge percent tried, and many of them did succeed. But even though they went into treatment, they still wanted to be peer health advocates. And so they were continuing to work with active drug users and deliver their intervention, but not necessarily in the high-risk settings where they had originally used themselves, because as part of their treatment program, they want to avoid those places. Nevertheless, we thought, well, if they can do it in the original RAP, maybe we can structure it in such a way that they can do it when based in a drug treatment clinic. And so the other thing we know is that drug users who go into treatment try maybe very hard to avoid people, places, and things that are triggers for relapse. But a lot of times you can't eliminate your brother or your cousin or your neighbors. I mean, they still live in the same place often. They can't completely escape. And so there are still a lot of people around them who use, even as they're in the process of getting clean. So we know, and they know, that they still have access to people who could benefit from harm reduction messages. But there were some questions that we had to answer. If we're going to implement RAP in a clinic setting, in a drug treatment clinic setting, what about the clinic setting? Is that a place where this kind of intervention could be implemented? What is the readiness? Organizational readiness is really, in many ways, it's a theoretical question for implementation science. There's a lot of interest now in implementation science, and organizational readiness, which is multidimensional, is very nuanced, from the structure, the administrative structure of the clinic, to the values and beliefs of the people in the clinic. So these are all really important questions. A lot of times, treatment counselors in clinic settings don't necessarily agree with the harm reduction approach. You have to go get clean, and there are no options. It's a clean only kind of a thing, and you stay away from all drug users. And so if there's that a very strong tendency in that direction, well, then RAP might not work because it's a harm reduction intervention. So we had to think through some of these questions. And another part of that is, clinic patients, what are their connections? Can they leap the wall from the clinic back into the community to deliver this intervention? So how would RAP have to be fitted, sort of retrofitted to a clinic setting? And what would be some of the challenges if we tried to do this? So we got an R34. I don't know if you're familiar with the R34 mechanism. It's the R21 is a 2-year exploratory pilot developmental study. The R34 adds a third year to allow you to pilot an intervention. So it's a very similar method to the R21, but it does allow for that third year of intervention piloting. So we got an R34 to translate RAP into a clinic-based program, working with the Hartford Dispensary very closely to go through that, the curriculum for training PHAs and the procedures for how to, who would be delivering it in the clinic and how would they do it and how would it fit in with the other therapeutic and health education programs of the clinic and so on. So we took a year to do that. And then we piloted it with several clinic patients. So we used that and then developed all the materials for potential scaling up for implementation in the clinic. That was our goal with the R34. So we also used, again, as we often do, mixed methods to examine the questions of organizational readiness and understand more deeply the perspectives of some of the people who would be directly involved in this, in RAP implementation if it were done in the clinic. And we used in-depth interviews of staff, clinic staff, and clinic patients to examine things like their attitudes towards harm reduction. That was a really important thing that we knew. And, quick answer to that is it varied. Not surprising to us, it varied. We wanted to know about their ability and willingness to administer a program to train some of their caseload to become peer health advocates, their expectations about whether clinic patients would be good peer health advocates, and I'm talking staff and patients, asking them some of these same questions. In the clinic, we wanted to know if there would be the potential for allocation of resources to this intervention effort, although we built into the grant some of those resources because the clinic doesn't necessarily have them on hand. We asked about their expectations of the success or failure of RAP, and we also wanted to explore some of the community characteristics around the clinic that were really important because we weren't delivering the intervention in the clinic. We were asking clinic patients, with the support of clinic staff, to deliver the intervention in the community that surrounded the clinic. So those clinic staff needed to know about that community, which it turns out is an interesting thing because a lot of times clinic staff commute to the town where they work, and so they've been trained to be a drug counselor, but they haven't been trained to be an outreach worker. They may never have gone out into those communities where they're now potentially going to be working with clinic patients to deliver this intervention. So that was one of the crucial findings. I don't have it among these slides, but I just wanted to mention. So one of the things that we did as part of our formative work, and we worked, the Hartford Dispensary, although it's called the Hartford Dispensary, actually has 8 clinics around the state of Connecticut. And we worked with maybe 5 of them. We actually did an organizational readiness survey with all 8 of them, but we worked more intensively with the ethnographic stuff with 5 of them. And we did some community mapping in which we had kind of group interviews with a couple of the clinic staff, several clinic staff, a couple of the clinic patients, and then our ethnographic staff and gigantic maps of the community and say, okay, where are the drug use, where are the hot spots where there's drug sales going on? We want to avoid those hot spots. Where are the cool spots where drug users gather for social services, the soup kitchen, sometimes the public library. I mean, there's a whole bunch of different places, the park, where there aren't sales and use going on. Places where they could potentially go safely. We were looking for safer places for the intervention to be conducted and map them out so that staff would know about that. And like I said, a lot of times it was good that we had patients in the group because if they had not been in for too long, if they'd been in for a number of years, they may not know exactly where the hot spots are either because they move around. But that really helps to figure out, okay, well, see, here are some of the places we can go to do our outreach intervention. So we found it was really important to make sure that the staff had the capacity to do this. And the clinic recognized that a lot of drug counselors didn't really have the capacity. They needed to find and maybe even hire staff who had had some outreach experience, because it's not enough to know how to deliver a therapeutic intervention, do group sessions, et cetera, one-on-one, whatever that might entail. You really have to feel comfortable walking around the streets and talking to people about health promotion. And so if they weren't comfortable with it, how are they going to help the peer health advocates to be comfortable with it? So that was a really important thing to find out. It was also important to realize that RAP couldn't be this thing floating out here in the clinic. It had to be fully integrated, just by virtue of communication ties, if nothing else, with the other therapeutic programs of the clinic, so that they could be mutually reinforcing. A lot of times, the clinic staff who were drug counselors could recommend good potential peer health advocates, and then could also reinforce the work of the peer health advocate as they were going along. So that kind of cross connecting within the clinic became very, very important, both for the program in the clinic and for the clinic patients who wanted that message sort of reinforced. The patients themselves needed ongoing support, which with this little pilot, we didn't have a lot of time to provide that, but that was not different from the original RAP. We found that many of the findings, many of the results were not different from the original RAP. So I just wanted to give some examples. Now these quotes are from Kristen Kostick, who was a former RETI alum, who her project was really connected to the RAP translation project, and she was exploring some of the ethical questions of peer intervention training and delivery for drug treatment clinic patients. So she, worked closely with the project throughout that translation and implementation pilot, and did a number of in-depth interviews of staff and patients. And so here's just a couple of quotes. It's given me a purpose in my life now. I really never had a purpose to do anything. It's given me a purpose to do something to help people live better. And helps me with my sobriety, helps me feel good about my sobriety, another reason to stay on track. And I learned so much from it. It helped me stay clean. Not only what I learned, but I get to pass it on to others. So again, these are sort of echoing what we heard from the original PHAs in the original trial, that it had the same kind of effect, the same kind of change in their self-perception, change in the perception that others had of them. So at the very least, we felt like it is potentially quite possible to deliver this kind of intervention and have it be as effective. We knew that we needed to have more training over time than just what we were able to do. That the whole CAG was sort of reinforcing the training that they got in the original curriculum, and people need that, something to come back to. They needed debriefings after they went out, informal meetings. And so all of this long-term support of the program and support of PHAs in the program really needs to be thought through in the clinic context. So where can we go from here? And I'll be honest with you, we're a little bit stuck. We've been trying to get NIDA funding to test the scaling up of, actually really test it in a formal way in clinic settings. The combination of all the budget cutbacks and how much more competitive it is right now, it is just a general struggle in terms of getting funding. But there are some particular challenges for this, based on some of the reviews, that I think are really difficult to overcome. And one of them is, how will this be sustained after the trial is over? We can build in some of the costs of the intervention while we're testing it. And I think we have a pretty good design to test it in multiple clinics over time. It's very labor intensive. It's a very labor intensive program, so you have to have set aside staff. It's not the kind of thing where, you know, when drug treatment clinics shifted to motivational interviewing, they were shifting from, what is it, cognitive behavioral therapy to motivational, whatever it is. They're just doing the same thing, only in a different way. And might be a better way, more effective way, but it didn't require them to take on a completely different role. For example, of going from a group or one-on-one interventionist to someone who knows their city and will go out and do outreach, someone who is really training and facilitating. It's a different kind of a role, and so it requires staff. And how do you pay for staff? Well, most staff in treatment clinics are paid for by whatever, the clinic fees, but also things that are reimbursable. So we're starting to look into how this can be supported in a sustainable way through third-party payer. It gets complicated. It's very complicated. So we haven't quite figured that out yet, which means until we can answer that question and have a really good answer for it, then it may be hard to be able to get this scaling up implementation trial funded. So that is, so there's the reality that comes along with that kind of technical criticism of the intervention. It has to be done in such a way that it really can address those long-term questions about implementation of RAP. So that's my story. I'm sticking to it. And I wanted to thank, there's just actually a lot of people to thank. This is the combination of high-risk sites, RAP, and the RAP translation projects, staff. There were a lot of people involved at the Institute for Community Research, and of course there were people involved at the Hartford Dispensary, and then of course there were the PHAs who were amazing, a lot of them just truly amazing. Some of the publications that came out of RAP, more RAP, and the RAP clinic publications, and some from way back in the history of time from high-risk sites. So those, if you just needed those references for any future use, feel free. So I will open it up to your questions. Thank you.